Pearse Keane is a consultant ophthalmologist in Moorfields Eye Hospital in London, and he's associate professor at University College London Institute of Ophthalmology. The connection and the reason part of the reason I invited Pearse is he's originally from Ireland. He's from, he graduated from University College Dublin, which is also where I went to university. In 2016, Pearse initiated a formal collaboration between Moorfields Eye Hospital and Google DeepMind, and his aim was to develop artificial intelligence algorithms for early detection and treatment of retinal diseases. In August 2018, he published the results in Nature Medicine, and he's published more papers this year in Nature Medicine about this collaboration and using artificial intelligence for early warning signs of age-related macular degeneration. Pearse has been listed in the Evening Standard as one of the most influential Londoners, and also was profiled in The Economist earlier this year. And he was also on the Power List of Ophthalmologist magazine, ranking in the top most 100 influential people in the world of ophthalmology. So as Pearse knows, so one of the reasons that I decided to invite Pearse also was because the last time I was at home, which is now almost a year ago, there is a Christmas series, I don't know if anybody's aware of this, called, it's basically the Royal Institution in London does this Christmas series of lectures. And every child, at least when we were kids, over the summer or over your Christmas holidays, there was this week of these lectures, and they were all by scientists, and they probably influenced many, many children to become scientists and doctors and engineers. And so last year when I was at home, who was giving the Christmas lecture series except for Pearse? And I was like, wow, Pearse is famous. He's like influencing new kids to do artificial intelligence. And so because it's sort of very, they have to present it in a way that's very kind of obviously accessible to people who don't know anything about it. And so I thought, I don't know anything about artificial intelligence, so I'm going to invite Pearse and he can teach us about artificial intelligence in diabetic eye disease.
Oh, well, thank you, Emily. That's lovely, lovely to hear that introduction. So let me share my screen, and okay. So yeah, I thought it might be interesting to tell you a little bit about some of the latest advances in artificial intelligence, and in particular a technique called deep learning, and sort of see beyond the hype around AI and see actually, does it indeed have the potential to transform healthcare? And spoiler alert, I very much believe that it does. And what I'd like to do over the course of the next 45, 50 minutes or so is actually just tell you about what we've done in ophthalmology and see whether there's any lessons that could be applicable in diabetes, in endocrinology, or in other medical specialties. Now, Emily's already summarized my background, but just to remind you, I'm a consultant ophthalmologist at Moorfields Eye Hospital in London. And Moorfields Eye Hospital is the oldest eye hospital in the world. And at Moorfields, I specialize in the treatment of retinal diseases. So in particular, age-related macular degeneration, or AMD, which is the commonest cause of blindness by far in the UK and by far in the US. But also diabetic eye disease, which is the commonest cause of blindness in working age populations in many countries around the world. I'm also an associate professor at the Institute of Ophthalmology at University College London at UCL. And then lastly, I'm very fortunate and privileged to be funded by UK Research and Innovation as a Future Leaders Fellow. And so this puts me in a very nice position where about 80% of my time is protected for research. And I only do 1 day a week in clinics seeing patients. The other thing that I should highlight in terms of financial disclosure is that I have acted as an external consultant for the artificial intelligence company DeepMind, whose parent company is Google. And I act as a external consultant for Roche Genentech. And I think you'll see over the course of the next hour why I'm particularly highlighting that financial bias. So in terms of what I'd like to cover, I thought of a few main areas. And so really, thinking about maybe 2/3, maybe 3/4 of the talk would be about the collaboration between Moorfields and the artificial intelligence company DeepMind. Then I'd like to tell you a little bit about this study that is really just in the early phase, is called the ALS Eye study. And I think that this is something that'll be interesting to you as diabetologists and endocrinologists, which is to say, it's the idea to build on this age-old idea that we can use the eye as a window to the rest of the body. And the idea that, you know, given sufficient data sets and given the powers of deep learning, we can kind of supercharge our previous abilities. And then lastly, I'd like to kind of speculate a little bit, to conclude by speculating a little bit about an emerging ecosystem for clinical AI. And really, one of the things that I believe is that we're moving from, we're almost at the end of the beginning in terms of AI-enabled healthcare, or near the end of the beginning. And in this early phase, there's been this kind of focus on kind of bespoke deep learning models, kind of like an artisanal approach, essentially, with world-leading computer scientists who are developing these models. Whereas I think we're very soon going to enter a phase where actually that's going to change, and it's going to be less about the innovation on the computer science side, but more about the innovation on the clinical researcher side. And I think, of course, I'm hugely biased in this regard, but I feel that in this coming phase, it will be clinical researchers who are central to the development and application of clinical AI. So why do we need new technology and innovation, and in particular AI in healthcare? Now, of course, maybe it's just a way to publish papers and kind of get grants and things like that, but I think it's something bigger than that. And part of the reason why I feel we have this urgent need for it is this figure. And so this is something that I love to show other medical specialties when I'm speaking to non-ophthalmologists, particularly because I think, and maybe this is just in the UK, but there is a perception that ophthalmology is kind of like maybe like an easier medical specialty, or a cushy number in some ways, and maybe part of that is true, but at least in other ways it's not, because since 2017 in the UK, ophthalmology has surpassed orthopedics as the #1 busiest of all the medical specialties in terms of outpatient clinic appointments. So in fact, nearly 10% of all clinic appointments in the National Health Service in the NHS in the UK are for eyes, and that constitutes nearly 10 million appointments per year. And furthermore, that is a figure that's rising rapidly over the last 5 years, particularly as we have an aging population, and particularly as we have, you know, growing number of patients with diabetes, and, you know, however many patients that is in the UK, I think it's maybe 4 million, maybe 5 million patients. So huge numbers of people that we need to see and treat. Now, as a result of that, you know, the brutal fact is that we are drowning in the number of patients that we need to see, and that there are some patients who are losing sight because they can't be seen and treated quickly enough. And that's the case not just in the UK, but really in both the other countries in the developing and developed worlds. So what I believe is that AI may play at least some role in addressing this, and I don't mean to claim at all that this would be a panacea, but when I talk about AI, really I'm talking about a technique called deep learning. And in 2015, Scientific American listed deep learning as one of their world-changing ideas of the year. And in fact, ever since that article in 2015, much of their top 10 list every year has been kind of AI-based. And deep learning has really led to transformation of the world's technology companies, and you know, is beginning to transform healthcare. Now, what is deep learning? Well, deep learning really is just a rebranding of an idea, which is that of an artificial neural network. And artificial neural networks are a concept that have been around really since the 1950s, when they were called perceptrons. And really these are computational models that superficially, and I underline superficially, that superficially resemble the brain in the way that they process information. And the key point is that they're, unlike kind of classical machine learning and computer programming techniques, they're not predetermined or pre-specified. So you don't engineer the features in a deep learning network. So what that effectively means is that, you know, pre-deep learning, if you want to teach a computer to be able to recognize a photo of a cat, you have to code a description of a cat that a computer can understand. Cat has fur, cat has whiskers, cat has tail. Some cats are ginger, some cats are not. Some cats don't have whiskers, some cats don't have tails, etc., etc. And the problem was that even when people would write hundreds of thousands of lines of code, the systems were never quite accurate enough. Now, what happened with deep learning is that people realized that if you had 1 million pictures of a cat, you could essentially upload them to a neural network and just say, this is a cat, this is a cat, this is a cat, this is a cat, and repeat over and over. And it would be able to learn to recognize a cat itself, and often with an accuracy that would surpass even human experts. Now, one thing to highlight as well is that oftentimes when you see these types of lectures about deep learning, you see a diagram like I'm showing you here, where you see a number of neurons, or often called nodes, which are the circles. You have a number of connections or weights which link them, and those are arranged in a number of layers. And I remember when I used to read about this when I was, many years ago, I always used to kind of scratch my head, because these things kind of just look like these very simplistic diagrams. But in actual fact, these neural networks are staggeringly complex creations. And so what I'm going to show you on the next video is just, this is a slightly more realistic depiction of an artificial neural network that I downloaded from YouTube. And the key point is that essentially what you show to the neural network here is a number, and the output of the network is, well, what is that number, 0 to 9? Now, this is a neural network with only 3 layers, and this is a neural network with only 2% of the synapses shown. So if you think of state-of-the-art neural networks, they can have hundreds of layers, and they can have potentially billions of synapses or connections. And so it's only really in the last few years that we've had the computational power to be able to actually train these neural networks. And this also highlights one of the other challenges with these networks, which is around the interpretability of them. And actually, they may be able to tell you it's a cat, but how do you know why it's saying it's a cat when there's billions of connections, billions of mathematical functions that are somehow making this output? So, as I've said already, this has begun to transform the tech industry, and this really began since around 2012. You have all the major tech companies, and in fact, the 5 largest companies in the world have all kind of pivoted in the last decade to be AI-first companies. So you've now got advanced image recognition capabilities on pretty much all the smartphones that are available. You can do things like translation. So if you're on social media and you've got family members or friends who are speaking different languages, there's usually no problem in actually, understanding what they say. And I'm sure we've all had the experience of like desperately using Google Translate with a patient when there's no interpreter or something else available. And then, of course, also contributed to things like speech recognition and speech generation. And so, it's got to the point where we take it for granted now that we can have voice assistants like Amazon Echo or the Google Voice Assistant, where we can talk to them and we can say to them, we can tell them to play any song in the world and they will play that song. And so I think of my own daughters who are 2 years old and 6 years old, and the fact that they will just say, Alexa, play the Frozen soundtrack, or Alexa, play Madonna on Spotify, and the song just comes, and they're growing up in a world where that's just kind of normal. Now, we started to see it move into healthcare really since about 2015, 2016. And so one of the first most prominent papers in this space was a paper from Stanford published in Nature, featuring the cover of Nature back in 2017. And this was, basically they got 130,000 photos of skin lesions, some of which were benign, some of which were malignant, and they trained a neural network to be able to look at a new photo and classify it as benign or malignant. And then they compared the performance to about 20 board-certified US-trained dermatologists. And actually, the algorithm did as good or better than those dermatologists. So, think about what the implications of that are for dermatology, for ophthalmology, and indeed for healthcare as a whole. Now, of course, we have to be careful here, and there's actually a ton of caveats to this. And let me tell you that this was published in 2017, but these systems are not actually in real-world use yet. And so it turns out that this was all done on kind of retrospective validation of these. And there's a ton of reasons why you have to be cautious in the application of deep learning in healthcare. And so one of those could be, for example, well, if you've trained this neural network on a white Irish population, will it work on Afro-Caribbean population? And actually the answer is probably not. So we need to be very careful about these things. In terms of ophthalmology, one of the earliest applications has been in diabetic retinopathy screening. And so probably one of the most influential papers in the field came from Google Brain in 2016 in JAMA. And essentially the concepts are very easy here. They got hundreds of thousands of photos from patients with diabetes, and they classified them as referable or non-referable diabetic retinopathy, and then trained a neural network to be able to do this. And they were able to show very good performance in terms of making that classification. Of course, lots and lots of caveats to that. Now, nevertheless, ophthalmology has been at the forefront in this regard. And I think this has been driven in large part by the fact that there is large publicly available diabetic retinopathy datasets that have been available since the 1990s. And so, in fact, in 2018, the company IDX, which are now called Digital Diagnostics, had the first FDA-approved autonomous AI system across any medical specialty, and that's for diabetic retinopathy screening. And then in August of this year, you had another company called iNuke or iArt, and they also received FDA approval. So those are the two of the first autonomous AI systems that have received FDA approval. Now, I should say, whether they're widely used or not is another question. Now, and if I go then to talk a little bit about my work, the work that I'm involved with. So as I said, I'm a consultant at Moorfields, and in July 2016, Moorfields initiated formal collaboration with the AI company DeepMind. Now, DeepMind are a company that were founded in 2012 in London, and two of the three founders are alumni of University College London, UCL, which is affiliated with Moorfields, and two of the three co-founders are from London. And indeed, the headquarters of DeepMind is in the King's Cross area of London, which is just 2 stops away from Moorfields on the tube. Now, they were founded in 2012, and they were acquired by Google in 2014, reputedly for about £400 million. And the reason they were acquired was because they had great success in using video games as a testbed for artificial intelligence systems. Now, their landmark work really came in 2016, though, and this was published in Nature and featured on the cover. And this was teaching an artificial intelligence system to be able to beat the best human professionals at the board game Go. And for those of you who are not familiar, Go is kind of like an Asian version of chess, to put it in like brutally simple terms, but actually is much more complex than chess. In fact, there are more potential positions on a Go board than there are atoms within the universe. And so it was regarded as being a great challenge to artificial intelligence companies, to artificial intelligence systems, to be able to beat the best human professionals, because the sort of brute force approach that they would use to beat someone like Garry Kasparov in chess was not able to be applied to a game like Go. And so in any event, they were able to develop a system that beat the #1 players in the world in 2016. Now, they've had a variety of other successes, but I think one of the things that some of you may have seen just in the last week or so was this really, really, I think, thrilling success in the field of protein folding. And so this was reported in Nature and sort of news outlets around the world as being a very big leap forward in terms of using artificial intelligence to solve protein structure. So to predict a protein structure from the amino acid sequence. And so this is not yet in a peer-reviewed publication, but the thing is that there's yearly or biannually this competition which is around predicting protein structure. And so at the end of November, the results of this year's competition were announced. And essentially what it showed was that their algorithm this is compared, the performance of their system compared to 100 other teams that took place in the competition, when basically they were able to solve more than 80% of the protein structures in this contest. So, I mean, this is an area that I really know very little, if anything, about, but it suggests that this could be a very big breakthrough in the future for things like drug discovery. So, what are we working on in ophthalmology? Well, essentially, our idea was to apply deep learning to OCT scans. Now, OCT stands for optical coherence tomography, and OCT is now the dominant imaging modality in ophthalmology. So we do more OCT scans than all other ophthalmic imaging combined. In fact, we probably do more OCT scans per year in the UK and the US than we do things like CT or MRI scans. So it's on the order of tens or hundreds of millions of OCT scans. And OCT is kind of like an ultrasound, but it measures light instead of sound waves. And it gives very, very high resolution. So it's about 5 micrometer resolution. So it's an order of magnitude better resolution than an MRI. And even better, it's done in quick and easy, non-invasive fashion. So we do thousands of OCT scans per day and per week at Moorfields. So we approached them, and essentially we said, look, there are people losing sight because they cannot be seen and treated quickly enough. And we're also doing thousands of OCT scans per week, not just at Moorfields, but around the world. So let's develop a deep learning system to evaluate these OCT scans to prioritize those people with the most sight-threatening disease. So as Emily said at the start, in August 2018, we were able to publish the first results of this collaboration in Nature Medicine. And you can see that there's more than 30 different collaborators on this. It was jointly led by myself and a guy called Olaf Ronneberger from DeepMind. And this is a real multidisciplinary collaboration between academia and industry, including, clinicians from Moorfields, scientists from University College London, and computer scientists and engineers from DeepMind. Now, it was tremendously exciting for us because it was not just published in Nature Medicine, but it was featured on the cover. And then, of course, this being AI, you can't escape the hype. And I think that's certainly very exciting. And as someone who has published a lot of research papers that I've loved, but no one really other than me has really read, it's really exciting to be able to actually sort of disseminate your results in this way. And you can imagine how exciting this was for my mum back in Ireland to be able to kind of tell her relatives about how great her son was and all of this sort of stuff, and share it on Facebook, etc. But at the same time, also quite awkward, because the fact of the matter is we have not saved the sight of millions of people. And I just want to be really clear, we actually have not used this in real life in even a single patient yet. So this to me speaks to the challenges of actually taking a piece of experimental code that you use in a research paper and actually seeing how you can actually take it through FDA approval, get payer approvals, do robust clinical validation, et cetera, et cetera. And this is a multi-year process that I'm discovering is actually much more challenging than the early phases of the work. But nevertheless, we're really excited about what we've done. And here's an example of the system in action. This is a patient in their 40s with poorly controlled diabetes. If you look at the bottom row, you can see this is the OCT scan. And I don't think you have to be an ophthalmologist to figure out that this person has diabetic macular edema. So the retina has become very waterlogged. The system consists of 2 neural networks. And the first neural network is a segmentation network that delineates all the pathology on the OCT. So in this case, it's delineating all the intraretinal fluid. On the second row, it actually creates a heat map of the intraretinal fluid and the thickness of the nervosensory retina. And then a second neural network then is a classification network. And you can see the outputs of that on the top left. And it says, in this case, it's recommending semi-urgent referral to a retina specialist. And it's saying that the diagnosis probability is macular retinal edema, 98.5%. So remember that the aim of this is triaging the scans rather than actually making the final diagnosis. So the ultimate use case is that this could be used in a community optometrist, or maybe in a pharmacist, or maybe in a family practice, or maybe a general physician or general ophthalmologist, and then highlight those people with sight-threatening disease to come to someone like me. I'll also show, this may be slightly less interesting for you, but this is an example of a patient with age-related macular degeneration, or AMD. And as I said earlier, AMD is the commonest cause of blindness in the US. So in fact, about 800 people develop the blinding forms of AMD every single day in the United States alone. So the numbers here are quite staggering in terms of the impact of this condition, of this disease. And again, it's segmenting the pathology on the scans, and then it's saying this patient needs an urgent referral, and diagnosing the patient with choroidal neovascularization, which is or CNV, which is the hallmark of wet age-related macular degeneration. Now, once we had developed the system, we wanted to evaluate its performance. And so the validation that we did in the Nature Medicine paper in 2018 was essentially on a large retrospective data set. And I think that's an important point to highlight, but as a limitation. But nevertheless, we did get about 1,000 patients who had come to Moorfields as new referrals, who had had an OCT scan at first presentation. We looked at the diagnosis that was made when a range of different imaging could be performed, seen by a senior clinician, treated, and followed up for a period of about 6 months. And we used that as a reference standard. We then ran the algorithm on all those 1,000 scans. And the primary thing we were looking at was the errors on the referral decision. And so basically it had a 5.5% error rate on the referral decision. So lower is better in this regard. Now, the thing is, we wanted to benchmark that against human expert performance. So we got 8 human experts. So expert 1 to 4 are consultant ophthalmologists at Moorfields who are retinal specialists. And some of them have more than 20 years of experience and are world leaders. And experts 5 to 8 are optometrists at Moorfields, some who have varying levels of expertise. So we locked them in a room and we said, look at these 1,000 scans and make your triage decision. And in actual fact, this is how they did. So it's perhaps not a surprise that our AI was better than all 8 human experts, except for experts number 1 and 2, where the system was better, but it wasn't statistically significantly better. Now, there is, as ever, an important caveat here. And one of I think a good rule of thumb for whenever you see media hype around AI and, beats the best doctors, like almost certainly when you actually read the paper, you'll see that, the doctors are not doing a task that they do in real life, or they're doing that task with one arm tied behind their back in some way when you drill into the details. And so this is not a fair comparison, because the human experts would never look at an OCT scan in isolation in real life, even if just in a rapid access triage situation. So to make it fair to the human experts, we actually said, we got them to repeat the exercise, but we said, not only do you have an OCT, you would have all the stuff you would have in real life. You would have a retinal photograph, you'd have the visual acuity, you would have some short history or clinical vignette describing the patient situation. And so we repeated the exercise and got them to look again. And it wasn't a surprise then that all of the human experts did a lot better. And in fact, expert number 1 was able to equal the performance of the algorithm using the OCT alone. Now, as an aside, I should say that there is a real lack of information about human diagnostic accuracy, both in ophthalmology and I think in other medical specialties also. And so it was interesting to us that when we looked at that, some of the optometrists here actually performed better than some of the consultant ophthalmologists in terms of their diagnostic accuracy. And I think there is a need in general for all of medicine to have better benchmarking of human performance in this regard. Now, what did the system get wrong? Well, I'm not going to go into the details here for the confusion matrices, but what the BBC said was that AI did not miss a single urgent case. Now, what was interesting was that actually when we looked at the top human expert, who's a world famous ophthalmologist, and we looked at what he or she got wrong, actually, a lot of the time, they were very ambiguous cases. And a lot of the time, when we looked at our reference standard, and with the benefit of hindsight, we said, actually, maybe the best human expert has made the correct answer, and our reference standard is incorrect in this case. What was interesting, that was also the case for the artificial intelligence system. Now, I think that this is going to be interesting for a number of reasons. I think one of them is going to be around medical education. And so a book that I've been really influenced by in the last few years is Deep Thinking by Garry Kasparov. And what's interesting is the last chapter of that book concerns essentially the aftermath when Kasparov has lost to Deep Blue, and he's kind of contemplating like what happens next. And so he pointed out a couple of interesting things. So the first is that like people didn't stop playing chess. And actually, in fact, what happened was people started to use chess computers to train. And the result of that was twofold. So the first is that people got a lot better more quickly. So you have much more grandmasters at an earlier age than before. In the last century, it was Bobby Fischer and Garry Kasparov as young grandmasters. But now you've got quite a few more. And then the other big thing was that there's a much wider geographical distribution of chess playing talent now than there was before. And this is all facilitated by these systems. And so what I feel is actually, if I'm supposedly, an OCT expert, and it's taken me 10 years at a large center to get as good as I am at interpreting OCT, I bet you could get a medical student to be better than me in 10 weeks or maybe 10 months if you had the right data and you had the right tool to teach them how to do it. So where we're at with this now is we're trying to think about how we can bridge the AI chasm. And this is the idea that we took from the tech world, but this idea that actually it's one thing to do a cool demo. And actually in our terms, a cool demo is a peer-reviewed publication. But actually there's a massive gap between actually scalable deployment of a machine learning system. And if that's massive in the tech world, but it's even more massive in a healthcare setting. So there's a lot of things you need to do. And one of them is to work on the technical maturity of the system. And so in last year at Wired Health, we were excited that we did a live demo of our system. And this was after we had taken the algorithm from the Nature Medicine paper, and the team from Google had actually rewritten it from the ground up so that they developed it into a cloud-based API that runs in a fraction of the time and with a fraction of the computing power. And we did a live demonstration of this on a patient's OCT at Wired Health. So the analogy that I would use is that for the research paper, we've built a concept car or a prototype car that beats the world land speed record. But now we have to think about how we can actually re-engineer that so it can be a production car. And that's a considerable challenge. The other thing is the clinical validation of these systems. And so, we were involved in a systematic review and meta-analysis that was published at the end of last year. And basically, the upshot of that is that all of these deep learning systems in medical imaging, the methodology used in their validation is pretty terrible in almost 99% of the published literature so far. And so we need much more robust clinical validation of these systems. And that's beginning to happen. Now, one of the things we're really conscious of with our system is that, we've trained it from data from Moorfields, but we need to make sure that it works on OCT scans from patients from all over the world. And so we're, doing validation studies where we're looking at, will it work as well in a patient from Ghana or from Brazil or from Mexico or from the US or from many other countries around the world. And so we hope to publish those results in 2021. And then the other big challenge with these things is around regulatory approval. In particular, FDA approval is reckoned to be one of the most challenging. And in fact, one of the things that I always remember from a talk from IDX, the company with the first autonomous AI system approved in 2018, was they gave a talk at ARVO that year, which is the big ophthalmology conference. And they showed a photograph of the stack of paperwork that was required to get FDA approval. And it was about 6,000 pages, and it's taken them about 7 years to get that approval. So it speaks to that being the real major challenge in making these things happen. But what we really want to do is figure out how we can go from code to clinic. Moorfields is building a new eye hospital in the King's Cross area of London beginning next year. And so we're already thinking about what new pathways of care we can institute so we can actually have the flexibility to take advantage of these systems and not just replace what we have or improve what we have, but actually change the paradigm of the way that we deliver care. And of course, in some ways, that sort of thought process has been facilitated by the changes we've had to make over the last year with the pandemic. The other thing that we're really keen to do is much better link the community with the hospital eye clinic. You increasingly now have OCT usage in community optometry settings. So we need to add the telemedicine infrastructure to be able to link those community settings with the hospital eye service. And I think the promise of AI in that regard is, can we bring world-class expertise into the community and into the home and reduce the burden of many of these chronic diseases on our patients? So I'm going to tell you a little bit about another spin-off project from the Moorfields DeepMind collaboration. And the background to this project is that when we choose deep learning projects, we really try to focus as our North Star on projects with real patient benefit, where there's a real need. And then secondly, what we try to do is identify suitable data sets. Because the fact of the matter is that deep learning is very powerful when you have very large data sets in a tractable form and you have a relevant clinical question. And it is not any better than other techniques when those conditions are not fulfilled. So where you have overlap between these two things is really where we think the magic happens for this sort of work. Now, in that regard, one of the things we know as ophthalmologists is that if you're a patient who's lost sight in one eye from a disease such as AMD, can be very stressed about the possibility of it developing in your good eye. And so we wondered, could we use AI to predict the future development of a condition such as wet AMD in the good eye? And if we could do that with high enough certainty, could we consider some preventative treatment like intravitreal injection, some long-acting agents which are in the development, such as the port delivery system, or maybe even novel therapies such as gene therapy, which are in early phase clinical trials at the moment for this. Now, we worked on this from about 2018 to about 2020. And so on May 18th, which happens to be my birthday, we published in Nature Medicine another paper from this. And just to highlight the key role that one of my PhD students, in fact, my first ever PhD student, Reena Chopra, played as joint first author in leading this work. And essentially what we did was we created a clinical setup, which was that when we had patients diagnosed with wet AMD in their first eye, and they're attending the eye clinic regularly for intravitreal injections, that we're always taking OCT scans of both eyes. I mean, that's just a standard of care in ophthalmologists around the world. And so then we have the perfect substrate for if something develops, for analysis, if something develops in their good eye. And so what we did was develop this deep learning system with the aim of predicting development of wet AMD in the good eye within a 6-month time period. And we described that as being imminent conversion. And we felt that this was a kind of clinically meaningful and clinically actionable time period. Now, I'm not going to go into this paper in too much detail, but one of the key takeaways is this figure here. And the key line to look at is the blue line, which is basically the performance of the system in predicting imminent conversion in the good eye. And the key point here is that the area under the curve is about 0.745. And let me tell you, that is by no stretch of the imagination could that be described as a spectacular area under the curve. But I think that for me highlights 2 points. The first is the challenges around using AI for prediction of future events, particularly when there's a significant random element to that development, and particularly when you're thinking of time periods such as 6 months. But the second thing is that actually area under the curve is not a clinically meaningful metric. It's a way that machine learning specialists use to compare the performance of their algorithms, essentially, for the most part. But really what's important is is where you select your operating point in the ROC space, because that determines your sensitivities and specificities. So in our case, we select what we call a conservative operating point, and this is an operating point with 90% specificity, so a very low false positive rate. And the idea was that with 90% specificity, we were able to pick up about 1/3 of cases that would imminently convert. And so if we're going to consider recruiting these patients for a clinical trial, giving them some preventative treatment, which has potential adverse effects, we want to have a conservative operating point. We want a low false positive rate. And we're not too bothered if we have some false negatives, because we're monitoring those patients anyway. So as with our other study, we felt that human benchmarking is important. And I think that this is really important for all of machine learning studies. And so this was interesting because it wasn't known that human experts could actually predict imminent conversion in the good eye. And we were surprised to see that they could, although the performance was not quite as good as the algorithm. And the other big problem, as you'll easily see, is that the variability of the human experts was quite wide. And then just to finish up really talking about this paper, just to highlight, I appreciate that this would only be interesting to the ophthalmologists in the audience, but that the test set that we used was about 5,500 scans. And the challenge we faced was that there was only imminent conversion in about 4% of those scans. So a really tough task. And in fact, even in the highest drusen volume percentile, the highest risk group, it was only 6.7% conversion. So again, speaking to the challenges that we face in doing this. So where are we going with this? Well, we think that although the area under the curve for this initial work is not spectacular, this could be one of the best ways to move towards clinical translation of deep learning systems, particularly in the context of a clinical trial. And a clinical trial can mitigate against a lot of the shortcomings of deep learning in clinical care, where it's actually quite fragile if it's exposed to data that's different from its training data distribution. And so what we propose is that you could actually use deep learning to identify patients that are in a high risk group for progression and then recruit them into your clinical trial. And so, you know, this is something that we're planning to start in 2021, 2022. So I'm going to tell you about, just in the last 5 or 10 minutes, about some other cool stuff that I think, and one of the most exciting is this idea that we can use the eye as a window to the rest of the body. You know, this idea is more than 100 years old. This is a retinal fundus photograph, as you'll all be aware. And we know that you can see signs of hypertension, signs of diabetes, etc., looking at the retinal fundus. But the exciting thing is that since 2018, we've learned that with deep learning and with the right data sets, you can actually go much further than that. So with deep learning, you can now say, this is a woman. And with deep learning, you can say she's 58 years old, she's not a smoker, she's not diabetic. And with deep learning, you can say her BMI is around 25 and her blood pressure is around 150/85. Now, if you're skeptical, you could say, well, okay, there are easier ways to tell if it's a man or a woman than applying deep learning to a retinal photograph. And in fact, there are easy ways to measure blood pressure than taking a kind of rough value from an AI system. But the reason that we get excited about this as ophthalmologists is that although I have been looking obsessively at retinal photographs probably for more than 15 years, and Emily knows it's probably longer than that, but essentially, I cannot begin to tell whether this is a man or a woman looking at the photo. And even though I know that this can be done by deep learning systems, I cannot do it myself now. So we're excited about this because we've now linked more than 3 million retinal photographs and 3 million paired OCT volumes from more than 300,000 patients with something called the Hospital Episode Statistic Database in the UK. So we know the ICD-10 codes of every patient who's attended Moorfields who's gone on to have any inpatient, outpatient, or emergency visits. In fact, we know every cardiovascular and neurodegenerative disease that those patients have had. And the numbers of incident cases are 2 or sometimes even 3 orders of magnitude bigger than other population-based studies such as UK Biobank. So we haven't actually really dug into we were only in early phases of starting our experiments on this, because it took us about 2 years to get the permissions to make this linkage. If you want to learn a little bit more about it, we published, or we didn't publish, an article was published about it in The Economist in December 2019. And that was really focusing on the attention to detail that we had in terms of our ethics and data protection and patient and public engagement around this data. And so it's really exciting that Hal Hodson, who's the technology correspondent for The Economist, wrote about and praised us for our attention to detail in this regard. So lastly, I'm just going to tell you about something else that I hope will plant some seeds with the people listening about the potential of AI and the next phase of AI. And that revolves around the idea that I think there's an emerging ecosystem for AI-enabled healthcare. Now, since 2015, much of our work has been with industry such as DeepMind and more recently with Google. But in recent years, we're also working a lot with academic computer science departments in UCL and Cambridge and elsewhere. But really where the future, I think, is clinical researchers leading this type of work. Now, one of the things that I often get asked when I give these types of talks is, will AI replace doctors? Of course, I don't believe that at all. But it was really exciting to me that in November 2017, I read this article in the New York Times called Building AI That Can Build AI. And this is basically a description how all the major tech companies have now built cloud-based automated deep learning platforms. So you can now, people with no coding expertise can use a drag and drop interface to train deep learning models. And that can be things like image classification, but can also be in other areas such as natural language processing and other fields of artificial intelligence. So when we saw this, we got really excited. And what we did was we downloaded 5 publicly available medical image data sets. We got skin cancer lesions, we got chest x-rays from adults and from children, we got OCT scans, all publicly available, and we got diabetic retinopathy retinal photographs. And we actually signed up to the free tier of a number of these platforms and started to develop our own deep learning systems without coding expertise. And the cool thing was that we got results that were pretty good within days or within weeks. Now, we published this in the Lancet Digital Health in September 2019. And it was really thrilling for me that Eric Topol, who's one of my heroes, had tweeted saying that this will be regarded as a classic paper when AI becomes part of every medical school curriculum someday. Now, an interesting aside is that during the review process, the editor said to us, the editor of the journal said, one point that we hope you will be able to address in this revision is to emphasize that these tools will not necessarily replace AI experts. And I couldn't help but smile when I read that, and maybe a little bit of schadenfreude, but it was nice to see the AI experts feeling a little bit under pressure for a change with this sort of thing. Of course, I don't believe that artificial general intelligence is going to be solved anytime soon. So I'm not worried about AI experts losing their jobs anytime soon. Now, I just want to highlight that much of our initial work has been with automated deep learning has been on vision classification models, but actually there's a flavor of automated deep learning called AutoML tables. And so this is for tabular data. And I highlight this because given the audience, I imagine that you may have access to large electronic health record data sets or digital health data sets around diabetic control, for example. And so you can actually develop machine learning models without coding expertise using something like AutoML tables. And then there's something called the what if tool. And this is a way that you can generate something called counterfactuals. So suppose you've developed a model to predict hypoglycemia in a primary care population, and it has a certain performance. But you can now say, what if I change the ethnicity of this patient? What will happen to the performance of my model? Or what if I change the age by 10 years? Or what if I change them from white British to white Irish or something like that? And you can use that to kind of probe the explainability of your models. So I'm really excited about automated deep learning because I think it could be a bicycle for the mind. And you know, this is an advertisement from August 1980 that I love. And it's just amazing. It's like a trip back in time if you actually read this advertisement, because at the time, and it seems sort of crazy now, but at the time, the idea of a personal computer was strange. And actually, for the people in the computing industry, the idea of a personal computer was actually kind of nonsense. So you had these famous quotes from people like Ken Olsen from Digital saying, there is no reason why anyone would want a computer in their home. And computers were mainframes that were made by IBM, that were used by corporations to do their payrolls. Why would anybody want a personal computer? But of course, people like Steve Jobs and Steve Wozniak and others had the vision in a garage in Palo Alto about making personal computers. And the personal computers they put together were kind of limited in many ways. But actually, they realized that if you empower people to do this, that actually they will come up with hundreds or thousands of new applications. And I think we could be at a similar stage in terms of AI-enabled healthcare, because ultimately, like, apologies if there's any engineers listening, but if you leave the engineers to their own devices, they'll just keep on optimizing a diabetic retinopathy screening protocol. Whereas actually, it's the clinicians, the clinical researchers who will come up with the novel use cases for these systems. So I say, if not you, then who? If you're interested in this, you can actually go and download some public data sets. You can sign up to the free tier of one of these platforms. Could be Google's, could be Amazon's, could be any of them, could be all of them. And you can play around with these things. And I guarantee you'll find it pretty intriguing. Now, 2 caveats to that. First caveat is don't use data from your own institution unless you have the appropriate approvals. And second caveat is nobody is suggesting that you could use this for direct patient care anytime soon. And all of the challenges that I've talked about for bespoke deep learning systems would also apply equally here. But I could see this as really being the early kind of proof of concept stage for many of these systems. The work that I told you about in the Lancet Digital Health was led by Livia and Siegfried from our research group at Moorfields, and also has more recently been led by a guy called Eddie Korat, who's recently moved to Stanford. And he's basically, I think, one of the world's best clinicians at using automated deep learning systems. And we've got some interesting papers in the pipeline from Eddie. If you want to learn more, and if you don't mind a bit of self-promotion from me, we've got a course at UCL and Moorfields called Introduction to AI for Clinicians, which is going to be on in February. And that will teach people how to use automated deep learning in a very step-by-step fashion. If you need data sets, we published a paper in the Lancet Digital Health in October, led by Zhao Liu and Alistair Denniston. We actually have chronicled all publicly available ophthalmic data sets, and we list them in the paper if you want to download them. And then lastly, and I know I've probably talked too long, my last 2 slides, where are we going with this? So in ophthalmology, I think we're moving really from the slit lamp biomicroscope, which is a technology that really hasn't changed for more than 100 years, to some radical changes in the 21st century around much more use of advanced imaging and much more use of artificial intelligence associated with it. I was fortunate to be able to write a short essay on this in the Lancet in December 2019 called Reinventing the Eye Examination, if you're interested to learn a little bit more of the vision that we have. And this was jointly written with Eric Topol in December of last year. And then my last slide, where are the next steps? Moving towards implementation, we need to go from code to clinic. And it turns out that that is way harder than many clinicians, including myself, might have imagined. I think AI-assisted clinical trials, use of machine learning to identify high-risk patients and then recruit them to clinical trials will be a relatively straightforward use case for these systems, certainly much easier than getting FDA approval for direct patient care. I think we're going to see a lot of AI-assisted scientific discovery, and maybe that's, predicting dementia from your retinal photos, or maybe that's protein folding for drug discovery, who knows? And then lastly, I think we're going to be moving much more towards democratization and industrialization of this technology in the coming years. And then last but not least, that's my email address. And if anybody would ever like to get in touch, I'd love to hear from you. Thank you very much.
Thank you, Pearse. That was really interesting and exciting. As I've cheated now because I've seen it before, and now I've learned more this time than I did last time. So I just keep learning from the presentation. I think there's one question in the chat, and if anybody else has other questions. So it looks like Dr. Rayfield is wondering, what do you think is the timeline for FDA approval of the OCT AI work?
I think that the timeline is probably I would say 2 years. I think it's 2 years and not 5 years, I would say.
Do you want to expand on that?
Or? So I think I think unfortunately the pandemic has delayed things substantially, and there's all sorts of questions around what is the best way to actually implement one of these systems. And so, for example, is this something that Google should do, or is this a technology that they should license to a device manufacturer as Zeiss, Topcon, etc.? And so we're working with them to kind of resolve those kind of issues at the moment. And then realistically, you know, I said 2 years because maybe I'm trying to be cautious about it, but I would like to see if we could get it done before then.
Okay, and then Dr. Stewart, if you want to unmute yourself, he has a comment and a question.
Yeah, so first of all, that was a really phenomenal and exciting talk. I'm not at all an AI person, but I realize that it's coming, and we should all be getting our heads into it. In that spirit, just for the Sinai people, Sinai has started an artificial intelligence institute. Sinai has got all these research institutes, such as the Diabetes Institute, but we now have the Hasso-Plattner AI Institute. So part of the mission of that is for people on this call who are Sinai based to get involved and the tools to make the tools more accessible. And then for Pearse, there also is this New York Eye and Ear Institute, which is the oldest one in the US and the biggest. And it might be fun, I'm thinking of Emily here, to think of ways to interact and share institutions. I think the UK with the National Health Service has a huge advantage over American institutions, where we can sample our institution, but we can't sample the entire country or even the entire county or even, you know, the states, et cetera. So in a way, the UK is, and most of the rest of the world is better positioned than we are for large scale data collection. In the US, we have the VA system lends itself to this. But here's the question. You know, in the spirit of the cornea being the window to the entire body, I was wondering about predicting renal, glomerular nephropathy and just renal diabetic nephropathy. That seems like low-hanging fruit, and I'm wondering, because there are hard metrics, proteinuria, GFR measurements, et cetera. So I wonder if anybody has actually explored that in AI terms.
Yeah, so there's a paper published maybe about 2 or 3 months ago from Singapore, also published in one of the Lancet journals, and they were able to use deep learning to predict, I think, GFR or some sort of nephropathy related things. I think they got good results, but not necessarily results that would be really clinically actionable type results. And so I think the challenge is that the data sets that they are using are still relatively small in deep learning terms.
And then I guess another variable there that really fits into AI that also Sinai is strong in is, you can have great control your whole life and still get diabetic nephropathy, or you can have horrible control your whole life with T1D and never get diabetic nephropathy. And there seems to be a genetic basis for that too. So Sinai is collecting whole exome, whole genome data on large numbers of people. And that might be another interface that would be fun for endocrinologists to explore.
Yeah, I think it's so exciting to think of the possibilities with this. I just want to tell you a statistic that one of my group has just found recently with the ALSI study, which is a study where we linked all of the data, and essentially we've looked at the outcomes of all people of all patients referred to Moorfields with diabetic retinopathy, and an interesting thing for me was that among patients over the age of 40 who were referred from diabetic retinopathy screening as proliferative diabetic retinopathy, as query proliferative diabetic retinopathy. So 19% of them, the 5-year mortality was 19% in those referred as query proliferative diabetic retinopathy. And as an eye hospital, we were kind of detached from that, but actually that was for me like a jaw-dropping kind of thing to realize. So, I mean, who knows where this can go if we actually can get the data sets to begin to probe these sorts of questions.
Yeah, a very, very great, fun talk. Congratulations.
So I think we're a little over time, but Alice, do you want to have the last question and then we'll let Pearse go?
Sure. I just had a question. Maybe I'm trying to make it so that artificial intelligence doesn't replace scientists, but do you think some of this data could be hypothesis generating for research scientists? For instance, maybe this is already known, but why you couldn't apply your data set to a different country? Does it uncover some kind of hypothesis about structure, function, genetics of certain diseases?
Yeah, I think definitely yes. Well, so there's a few things there. I'd say the first thing is this is not magic. And actually what's going to happen is as soon as more of these systems become commercially available, people will forget that they're AI within a day of using them. And then secondly, people will start showing all the flaws in these systems when you use them in real life. So they are not magic, and they'll only work well in certain scenarios. So they're not going to replace us anytime soon. I think to your point, there's definitely, I think this AI assisted scientific discovery is going to be the way forward. Like I imagine like 2030, I can imagine like the eye clinic of the future. You know, a patient comes in, they've got 10 different types of OCT images. We've got their genomic information, proteomic, metabolomic, all of this sort of stuff. We've got sensor from their smartphone or a ring they're wearing on their finger. We've got the environmental pollution levels in their community. We have all this data, and actually we'll have some narrow AI tools that will make some sense of small parts of that. And then we'll be the people who have to like put it together and make the decisions and figure things out for our patients.
Thank you. It was really great. And thanks, Emily, for inviting him.
I think Pearse is looking forward to coming to New York when the pandemic is over. So if we want to invite him back again in a year or two, he'll be more than happy.
Yes, please. That would be a delight. Thank you, Emily, for flagging that.
All right. Thank you very much.